Okay, so next few series of conferences is going to be geared towards emergency room radiology, and it's mostly geared towards the first years and the second years. So for the cases that I present, I would like first years and second years to speak up and tell me what you think, okay? So we'll start with this case. Does anybody have any observations? Don't criticize my films. And by the way, this is a great portable chest radiograph. If you've got your chest. So, did anybody have any observations? Anything in first and second years? Okay. Anybody have any observations here? Well, why does it look like? Why does it look like the mediastinum is shifted? First of all, patient's rotated. So, what's the rotation?
The rotation here is right posterior.
Yeah, so this is right. It's a right posterior oblique projection, right? So we describe by the part of the body closest to the image receptor. Since the portable film, the image receptor would be behind the patient. The right posterior part of the patient is closest, so it's a right posterior oblique projection. So we can judge that. We look for the clavicular heads relative to the spinous process. So where that is closer, that part of that shoulder is rotated towards you. Okay, so it's a right posterior oblique projection. Anything else? Any other observations? We're just going to dictate this. No consolidations, right posterior oblique, next case. Are we done? No?
Look for your lines and tubes. And
So does anybody want to say anything?
there's an enteric tube coursing, looks like below the diaphragm, side hole at the G junction.
All right, we kind of struggled with this long enough. Does anybody want to say anything now? Yeah, that's kind of a who cares. That's right. This is an esophageal intubation. Okay? So let's go back to the film. The rotation actually helps you here because it takes the tracheal air column off of where the ET tube is, right? Yeah, exactly. Right. So here's the trachea, here's the esophagus, this is esophageal intubation, and that's why there's gastric distension. Now, I've come across very few of these, and in every case that I've come across, there's been gastric distension. So what does that mean? If you have an intubated patient and you see gastric distension, please go back and look very carefully at the ET tube. 99.9% of the time it's going to be okay, but the one time in your career when you come across an esophageal intubation, please send me an email that says thank you. Okay. So the first thing we want to learn when we're looking at chest radiographs is you want to check the placements of lines and tubes first before you look at anything else. Any other abnormality can usually wait, but if there's a misplacement of a line or a tube, the results can be catastrophic if it's not corrected immediately. So always get in the habit of confirming placements of lines and tubes before we look at anything else on a chest radiograph. Okay, so here's the patient with the ET tube properly placed after they took it out here. So we absolutely want to recognize that immediately. What about this radiograph? What are we going to say here? Okay, so there's complete whiteout of the hemithorax on the right side. There are two major things that can give you whiteout. What are those two major things when we talk about whiteout? Yeah, so one is a large pleural effusion and the other is complete atelectasis of the lung. And of course the treatment is going to be different. Okay, so how do we differentiate large pleural effusion from complete lung atelectasis? We look for the mediastinum, the position of the mediastinum. If it's a large effusion, then the mediastinum will be shifted away. If it's complete collapse of the lung, then the mediastinum is shifted towards that side. So here we see that the heart is kind of shifted towards that side. So this looks like complete right lung collapse. So in that case, what do we think the cause is for this patient? So mucus plug would be the most likely explanation. So you would advise them to do what? Well, not necessarily suctioning. You start with suctioning first. The ET tube's already there. And then if they suck out the mucus plug, the lung expands pretty quickly, right? So we want to be able to, when we have whiteout, you want to be able to differentiate the major cause is because the treatment is going to be different. In this case, what are we going to say here?
It's in the right main stem.
So, and what's happening then?
Completely out.
Yeah, so there's complete collapse of the left lung in this case because the endotracheal tube extending too far into the right main bronchus, obstructing the left, so secretions build up there, and now you're going to develop complete left lung atelectasis. So you're going to tell them to pull back the ET tube, right? You pull back the ET tube, the lung expands pretty quickly, okay? Why does this patient have whiteout? All right, so here we would say that this is a large pleural effusion. Why do we think this is a large pleural effusion? Yeah, so here the trachea is shifted away, the heart is shifted away. So here we're going to think pleural effusion. There's the trachea over there, okay? So there's a CT scan on the patient, confirms a large pleural effusion. What's your diagnosis? There is cirrhosis. There is ascites. What do we call it if a patient has a large pleural? This is hepatic hydrothorax, right. So it's a patient with a large amount of ascites and cirrhosis. So this patient has hepatic hydrothorax. That's something we see quite a bit of around here. It's a liver center, a lot of cirrhotic patients, okay? Okay, how about this case?
There's no passing the retrosternal space.
Actually, the retrosternal space is pretty clear, right? That's pretty good.
This patient has a subcarinal mass.
Why do you think there's a subcarinal mass?
I kind of see some bulging at the AP window, and there is a complete
No,
donut
actually,
bite out of it.
well, not quite about the donut. AP window's pretty good here. So here's the aorta, right? Here's the pulmonary artery here. The AP window's in here, right there. There's nothing really bulging out from there. This is the main pulmonary artery here, and that's within normal, okay?
I'm trying to look at the neurostimulator.
What about it?
It looks like it's displaced out.
Yeah, it's slipping out.
Yeah.
See, on the lateral view, pretty sneaky, okay? So again, any lines, tubes, anything on the x-ray, you want to confirm placement of those things. Make sure you're happy with it. If you're not sure, ask. Okay, if something looks funny, ask about it. So in this case, this neurostimulator is slipping out of the spinal canal. How about this?
Dislodged tracheostomy tube.
Yeah, so this tracheostomy tube has come apart, and this portion of it is now fallen into the right main bronchus, okay? So there it is. Tracheostomy tube's dislodged. And prior chest x-ray, always compare with priors, they help, right? That's what it's supposed to look like. What about this case? Okay, right. So here we have, so there's a right subclavian line, that looks okay, but there's this enteric tube, it's coming down and going this way, right? There's the side hole. So this has gone into the airway, so of course we need to get this fixed as soon as we can. What about this case? Yeah, so what happens is with these tubes, once these tubes get into the lung, there's very little resistance. So if they push on the tube, it will keep going, okay? So what are you going to tell them to do?
Immediately retract the tube.
You're going to tell them to pull it out, right?
Pull it out.
Yeah, you're going to tell them to pull it out. That's all you're going to tell them? Is there anything else you should tell them? Why? Okay, so why, there's no pneumothorax on this film, why would there be a pneumothorax on the follow-up film?
Well, here the tube is plugged in the hole that just made.
Exactly, this tube is actually going all the way out into the pleural space, okay? So it may be tamponading the actual hole that's created within the pleura. So when you pull out this tube, there's a real risk that this patient's going to have a pneumothorax. Here's the follow-up chest radiograph. And what do we see? Yeah, there's a pneumothorax here, right, after pulling out the tube. So in situations like this, you do want to tell them to get a follow-up chest radiograph after they've removed that endotracheal tube, right? So there's a pneumothorax here. All right, so this patient has had a PICC line, and they have a follow-up x-ray here after placement of the line. So what are the things that we want to look for after placement of a central line?
So
Or
it's
pick
the left,
one.
it's kind of across the midline, which it's, what looks like it's diving to the
Okay, so the tip, you're happy with the position of the tip, first of all.
Maybe just the tip, but like the course of the catheter.
Is there anything about the course of this catheter you're concerned about?
Yeah, it should go to the SPC first.
You don't think that's going to SVC?
I think it's not as a no?
Well, to say a catheter is going to the azygos, what do we look for?
Coiling,
We look for that hook at the tip of the catheter as it hooks backwards into the azygos vein. Do we have that here? Yes or no?
Yes.
No.
No.
What's the matter with you guys? You're hallucinating now. No, there's no hook. Go straight down. So is the tip overlying the SVC? Yeah, why is that so hard to say?
Yes, it is.
Yes, it is, right? Okay, so you want to look at the position of the tip, the course of the catheter. Is there anything else you want to look at when you're looking at after a line placement? What else do you want to look for?
Like a move.
Right, you always want to look for a pneumothorax, right? Is there a pneumothorax here? No?
No, I think I said it.
Does this bother you at all?
Yeah.
Oh, now you're bothered.
No, I mean, no, I see lung like fields that have like.
All right, but it's a portable chest radiograph, right? I mean,
Questionable.
well, no, the scapula's out here.
I want to zoom in.
This is not the scap border. Okay,
So,
so is that a pneumothorax? You're going to tell them to put a chest tube, yes or no?
no, it's not, it's a skin.
How do you know?
It's well, pneumothorax would have like a white line. This is a lucid line.
Exactly, right. So what do we call that? This is a skin fold, but what the phenomenon you're describing is what? What is that called? You almost said it. Mock effect, right. So this is a negative mock effect, all right? So notice that it looks like it's almost like a little dark next to that, right? So that's a negative mock effect. And a skin fold produces a negative mock effect, whereas a pneumothorax produces a positive mock effect. And that's a nice way to differentiate pneumothorax from a skin fold. Of course, if you're not sure, right, what would you recommend? Yeah, get a follow-up, right? So don't be afraid of that. If sometimes you're not going to be sure, and then in that case, you're going to call them up, tell them to get an immediate follow-up chest radiograph. Okay, so that's a negative mock effect here next to that. So that's what we see with a skin fold, not a pneumothorax. Now that's a pneumothorax. Right? So a pneumothorax, we get this positive mock effect. With a skin fold, you get a negative mock effect. You see the difference? And that's nice because with a pneumothorax, that visceral pleura, that line looks even sharper. All right, so that's what you look for. You look for that sharp line of the visceral pleura. Of course, no lung markings peripheral to that and all that stuff. Right, that's what you want to see. So, I would refer you to this very nice article that describes, how we get mock bands, the physics of it. It's actually an optical illusion, as hard as it is to believe that. But so this article explains it nicely. So the point is, a pneumothorax gives you a positive mock effect. And what I like to say is for pneumothorax, you're looking for a line. You want to see a line. A skin fold gives you a negative mock effect. So with a skin fold, we don't really see a line, we see an edge. Okay? So there's a difference between an edge and a line, and that can help you sometimes if you're struggling with these cases. So this person has chest pain, presents to the emergency room, chest x-ray looks like this. What do we think?
juicy.
Yeah, so it's a very large right-sided pneumothorax. Of course, a question you're going to ask is, what will you ask them in the ER? Does this patient have any history of trauma? Right, no history of trauma. So in that case, if this occurs spontaneously,
It's like a young smoker, thin smoker.
well, what is it that we think might cause this? Yeah, so you're looking for a rupture bleb, right? So usually the workup of this is what?
CT.
Right. So usually if this case comes through the ER, the next thing they're going to ask you for is a CT scan, okay, to look for that, to look for the cause. So here's the CT. You can see the patient got a chest tube, okay? And what do we see on the CT? Yeah, so you have these subpleural blebs in the apices, okay? And so rupture of these quite commonly can result in spontaneous pneumothorax. And so, you know, they have criteria to use depending on if it's recurrent, when the patient would require resection, surgery to treat this, pleurodesis, et cetera, okay? But this is what they're looking for. They're looking for the underlying cause for the pneumothorax. They're looking for these types of blebs or emphysema. Okay? So here's our next case. If you think you see it, no? All right. Well, this is a common phrase that I get. Nothing jumps out at me. As if it is the responsibility of the pathology on the image to say, here I am, right? So what you want to have is a systematic approach when you review whatever type of study you're reviewing. You want a list of things that you're going to review, and it's helpful to review everything in the same order, to get in the habit of doing that, to have a checklist and to review it all in the same order, because the advantage of that is you start to get faster, and then you're able to review more and more things. Now, how do things get added to your checklist? When you miss them, right? So things that you miss, you should start adding to your checklist. And once you've added it to your checklist, and once you practice it, going through it systematically, you become very fast at doing this, all right? So what is on your checklist of things to look at on a chest radiograph? All right, so first we want to look at lines and tubes. Any problem here for lines and tubes? No. What else do you want to look at? Yeah, so bones and soft tissues. So, you know, the order I like to do is lines and tubes, heart size, mediastinum, bones and soft tissues, and then I'll look at the lung parenchyma last, and I'll take a second look to see if make sure you're not missing a pneumothorax or pneumoperitoneum. So make sure ask yourself that at the end of every case, you know, make sure you're not missing a pneumothorax or pneumoperitoneum. So you said bones and soft tissues. Anything there? What side? Yeah. So on the right side, right there. Okay. So, and you'll say, well, isn't this obvious clinically? Well, what happens is with a lot of the patients, you know, they may be obtunded, you know, they may have altered mental status. They're not able to say, my shoulder hurts. And especially patients who've been in the ICU, they get moved around a lot. So they can develop shoulder dislocations that are actually missed on the chest radiograph because, you know, we didn't look hard enough. So make sure that the edges of the film, bones, soft tissues, all of that, make sure that those things are on your checklist, okay? So a little bit more obvious example of the same thing, right? And again, these cases, this was not clinically apparent. These were picked up on the chest radiograph, okay? So, and then, you know, once you tell them, they'll go back and get a radiograph of the shoulder and it becomes pretty obvious, right? What about this case? So what's on our checklist?
Lines and tubes.
Lines and tubes? No lines and tubes, right? Next. Heart, looks okay? Yeah, it looks okay. Next.
Is the right shoulder too far downward from the AC joint?
No, it's okay.
The lungs are hyperinflated.
All right, so what? All right, so what else is on your checklist? Heart, mediastinal contours. What else is on your checklist on the chest radiograph? Lung parenchyma, pneumothorax, pneumoperitoneum, consolidations, right? All of that. But what have I not mentioned so far?
Visualize portions of the abdomen.
Yeah, those are okay. Anything else?
Effusions, pneumo.
Yeah, those are okay. How about the airway? Yeah, the trachea shifted to the right. Okay, look at, you follow the trachea down and it bulges that way to the right. Now, why is that, do you think? Yeah, this patient has a thyroid goiter. Okay, now the trachea is sitting right there in the midline. It has to be part of your checklist. Okay, so you want to make sure that you include the trachea in your checklist, the things that you look at. Because it is kind of embarrassing. I mean, there are cases that are even worse than this. It gets kind of embarrassing if you read a chest radiograph as normal and, you know, the clinician calls, you know, this guy's got a 8-centimeter left thyroid mass. And the trachea's like deviated all the way over here because, you know, you didn't really pay attention to it. Okay? What about this case?
Right lower lobe, opacity/consolidation.
Stop that nonsense. Tell me what you think this is. Your diagnosis would be what?
Pneumonia.
Yeah, pneumonia, right. Where?
Right lower lobe.
Why do you say right lower?
Sorry, no, right middle.
Okay. So how do you tell them apart? How do you know it's right lower lobe or right middle lobe?
That's right, the picture right there.
Okay, you can see, what is this guy here?
The minor fissure.
That's the minor fissure. So you can see that the consolidation is bordering up right against the minor fissure and it's underneath the fissure, so it has to be where? In the right middle lobe. What segment? What? Why do you say lateral segment?
You don't see the heart borders obscured.
Yeah, the heart border is pretty clear there. Okay, and then here's your lateral view. And on the lateral view, whenever we have opacity like that overlying the heart, you know, this is the region of the right middle lobe. Okay, so this would be then in the lateral segment because it's not obscuring the heart border. So not all pneumonias in the right middle lobe have to obscure the heart border, right? If it's in the lateral segment, not necessarily bordering on the heart, then it will not obscure the heart border. Okay, this case?
Retrocardiac opacity.
Yeah, so there's retrocardiac opacity, so what are you suspecting here then? Left lower lobe, diagnosis, pneumonia, right? Patient has cough, fever, or whatever. Left lower lobe pneumonia, you'd be suspecting. Now, does the lateral view help you?
Yeah, spine side.
Yeah, so the findings on the lateral view for the lower lobes. So the one thing you described, you said the spine sign. So for the spine sign, as you travel down the film, it should get blacker. This film gets whiter. That helps. What's another thing that helps on the lateral view? You lose the diaphragm. So you want to get in the habit of the lateral view of always looking for both diaphragms, okay? So you want to look for both diaphragms. This diaphragm is, which diaphragm is that? How do you know it's the right? How do you know it's the right diaphragm?
It goes all the way higher.
It goes all the way across, and you can see it through the heart shadow, right? The diaphragm that disappears, also there's colon underneath this, right, that helps. But the diaphragm that disappears when you get to the heart is the left diaphragm. So you want to get in the habit on the lateral view of looking for both, looking for the right and the left diaphragm posteriorly, okay? So if you don't see a diaphragm, you have to consider why is that diaphragm missing? So in this case, there's left lower lobe pneumonia that is obscuring the diaphragm, okay? And then when you compare with old films, it becomes even more obvious, right? And this is why comparing with old films really can increase your confidence in your diagnosis. That's what this patient should look like, right? No spine sign here. The film gets nice and dark as you travel down. So no problem now comparing that to that, wow, this is really a problem here. This is left lobar pneumonia. And then there's a frontal view there, okay? Different patient, somewhat more subtle, right? But the same thing. Retrocardiac opacity, and then as we travel down the spine, it's a little bit brighter there. Spine sign, it's another case of a left lower lobe pneumonia. What about this? Okay, so here looks like a right upper lobe pneumonia. You can see the consolidation there in the right upper lobe. And what segment? Well, on the right side, you don't have apical posterior. You have apical and they're two separate segments usually on the right side. Right? But most of that is posterior. Right? That's in the posterior segment. Here's the right upper lobe bronchus. There, that's the posterior segmental bronchus. So that's in the posterior segment of the right upper lobe. Back here, it's the posterior segment of the right upper lobe. Okay?
Lingula.
So why do we think it's in the lingula?
Bordering the left heart border.
Right, so this obscures the left heart border, so analogous to the right middle lobe, on the left side we have the lingula. So here, we're going to say that pneumonia is in the lingula. Again, the lateral view is helpful here. We can see the opacity overlying the heart. So when we see that on the lateral view, it's either right middle lobe or lingula. We can tell from the frontal that that's going to be in the lingula. So that's pneumonia in the lingula. And here's a CT. Why they get CTs on pneumonia, I don't know, but we have them. There they are. Nice correlation for me. So there's a nice pneumonia there. What do we think here? Okay, so we have a vote for right lower. There's the lateral view. What do you think? Yeah, right. So still, there's opacity back here, right? So that would make it right lower. Okay. And then again, comparing with the old study, very useful. You can see what this retrocardiac region is supposed to look like on the lateral view, right? So there's something there now that was not there before. So that's the right lower lobe. Right upper, and we know because again, here's the minor fissure. It's bordering very nicely on the minor fissure. It is above the minor fissure. That's going to be a right upper lobe pneumonia. And what segment is that? That's in the anterior segment, right? So here we can see the minor fissure going across. The opacity is here. So that's in the anterior segment of the right upper lobe. Okay. This one. So which is it, right middle or right lower? Why do we say middle? Yeah, so on the lateral view, there's no spine sign, but on the lateral view, we do have this opacity right there overlying the heart, even though the heart border is not obscured here. So here, we would think that that's probably in the right middle lobe. And again, nice correlation there. It's a right middle lobe pneumonia. So when the opacity overlies the heart like that on the lateral view, think right middle lobe or lingula, and then of course you go back to the frontal. I could tell you where it is. All right, so this one's a little bit tougher. Only on the lateral view, you have to tell me where the pneumonia is.
It's the left lower. It's the right lower.
So which is it? I got one vote for, well, I mean, we agree that it's going to be lower. There's a spine sign. So the question is it right or left? The envelope, please. The end. Right. All right. So why? Yeah. So look at the diaphragm here. So here's the left diaphragm, right? That's the one that disappears. Okay. So that's the left diaphragm. We can see it. The right diaphragm, we can see through the heart shadow, but back here it disappears because of the silhouette sign from the pneumonia. So that's a right lower lobe pneumonia.
left upper.
Where in the left upper
No,
lobe?
no, no, sorry. Because we lose the heart.
So we need a consensus opinion here. Do we think this is normal? Do we think there's a pneumonia? What
There's
do
a
we think?
pneumonia, but
Where?
left, because we're losing the left heart border, so left.
So where do you think it is?
So it's lingular.
Yeah, so if you think that there's opacity here and the left heart border is obscured, then you have to go with lingular. Here's the lateral view, right? And again, if you're not sure on a frontal view, especially if it's a portable, you can try to ask them to get PA and lateral views because you see how useful the lateral view is, right? So on the lateral view, where's the opacity? Yeah, right over the heart. Right. So this is a pneumonia in the lingula. Okay. And then again, old chest X-ray, very helpful. You can see what the left heart border is supposed to look like in this patient, and that's the patient with pneumonia. Comparing with the lateral view, somewhat more subtle, but it's there, overlying the heart. So that's a pneumonia in the lingula. Okay? Does this patient have pneumonia?
Yes.
Where?
Right, no.
Left lower.
We have the spine signs.
Yeah, we do have a spine
Spine
sign.
and diaphragm.
And when we look on the frontal, maybe there is some increased opacity here, right? So again, old chest X-ray, very helpful. Compare that to that.
Left lower.
Yeah. So old chest X-ray, this is a patient with a left lower lobe pneumonia. What do you think about this case?
Right upper lobe. Pneumonia. Or aspiration.
That's all you're going to say? Or is there something else you need to mention?
ASCT.
Why?
Could be a mass.
Well, is there, and you have, the patient has a cough, looks like there's a right upper lobe consolidation. Why are you worried about a mass? Why can't this community-acquired pneumonia, put them on antibiotics, send them home?
There's some volume loss in the right lower.
Right lower?
No, I mean, if you see, like there's,
So I'll give you a close-up. So you're going to send this patient home on antibiotics, or are you going to tell the ER something else?
Something's off.
What is it?
Any cross-sectional.
Why? I mean, unless you know the reason why, this patient's going home.
post-obstructive.
Well, certainly pneumonias can be post-obstructive, but is there anything here?
The fissure is distorted, which suggests atelectasis.
Yeah, you can get some volume loss with pneumonia. You can get that. Is there what? Where? Where? Hylar? What's this over here? Yeah, there's a paratracheal opacity that should not be there. Okay? So when we see that, we're going to be concerned about what? You said lymphadenopathy, right? So if there's lymphadenopathy here associated with this consolidation, now we're worried about post-obstructive pneumonia. So now you're going to recommend what? Any particular way you're going to tell them to do the CT? Should they do it as a P protocol, which is usually what you get from the ER whenever you read something abnormal on a chest radiograph? Should they do it as a non-contrast? How would you tell them to do the CT?
want to see if the nodes are enhancing, so.
Well, not so much the enhancement of the nodes, but first of all, do you want a PE CT in a case like this? Yes or no?
No, right?
No. Do you want a non-contrast CT? No. Why do you want a contrast? Why do you want a post-contrast CT then?
I mean, just to see the anatomy better.
If there's any abnormality in the mediastinum, if there's abnormality in the mediastinum or the hilum, right? Especially if there's consolidation and you think there's atelectasis, you want contrast because it's very difficult to differentiate tumor from collapsed lung on a non-contrast CT scan. Okay, so the rule I use is the larger the abnormality on the chest radiograph, the more you're going to need contrast to figure it out on your CT. Most people think, well, big abnormality there, non-contrast CT, be able to figure out what it is. No, it looks like a mess on a non-contrast CT. Okay, so now the reason you don't want to do it as a PE scan is that the PE scan is done very early in the phase of injection. And again, you want to be able to give time for lung parenchyma to enhance to differentiate parenchyma from tumor. And it's easier to do that on a routine CT on a routine chest CT where we wait a few minutes after contrast, as opposed to, an immediate CT for a PE. So in this case, what are we going to say?
There's a mass obstructing the right upper lobe, right main bronchus.
Right main bronchus?
Sorry,
Which bronchus is obstructed?
the right upper lobe is completely obstructed.
Yeah, the right upper lobe, here's the right main bronchus. The right upper lobe is completely obstructed, right? There's no right upper lobe bronchus here. Yeah, there's stuff here, right? And we do have post-obstructive pneumonia or atelectasis, right? And what other finding do we have? What was the paratracheal opacity? What does that represent? You see it? Here's the SVC. What is this stuff? Lymph nodes, right? These are lymph nodes. They're in the mediastinum. And any other finding? Liver metastases, right? So this is a patient with lung cancer and post-obstructive pneumonia. Okay. So you need to be suspicious from the chest radiograph, right? Anybody with pneumonia, look very carefully at the mediastinal contours. If there is anything that looks like mass or lymphadenopathy, that patient needs a CT scan with contrast, a routine chest CT, not a PE CT. Okay. So this patient, one of your ICU films, acute onset of shortness of breath. So what's abnormal on the chest radiograph?
So right middle and right lower, because we see the minor fissure, so I think there's atelectasis at the right middle, and also we lose the right heart border, so I think we lost atelectasis of both the right middle and right lower.
Okay, so what would do that? Yeah, so obstruction of the bronchus intermedius. So on a portable chest radiograph, or whenever you lose, if there's volume loss, here clearly there's volume loss, right? The heart is shifted towards the right. So when there's volume loss and you lose the right heart border and the right diaphragm, we think of combined collapse of the right middle lobe and the right lower lobe. And in that case, we think about a lesion in the bronchus intermedius or a mucus plug in the bronchus intermedius, something obstructing the bronchus intermedius. Okay? So when we lose the diaphragm and we lose the heart border, we think bronchus intermedius obstruction. In this case, you can see secretions actually extending down into the bronchus intermedius here, and then here we're starting to get collapse of the right middle lobe, back here we have collapse of the right lower lobe. Right, so in a case like this, you would tell them to start with suctioning. Patients with tracheostomy tube, endotracheal tubes, these patients have a lot of secretions. It's going to be pretty common for them to develop atelectasis from mucus plugging. Okay. Another patient with acute onset of shortness of breath. So here you're thinking about a left lower lobe atelectasis. Why are you thinking left lower lobe atelectasis? Okay, so a couple things. So we see the heart border, and then there's a retrocardiac opacity, right? But what else about the opacity? It obscures what? The diaphragm. It obscures the left diaphragm. So we have this wedge-shaped retrocardiac opacity that obscures the left diaphragm. You have a double density there. Heart looks like maybe shifted a little bit towards the left, but this is left lower lobe atelectasis. And then again, your lateral view, you notice what? Left diaphragm is missing, right? We can't see the left diaphragm. So this is a patient with left lower lobe atelectasis. On the frontal view, wedge-shaped opacity behind the heart that obscures the left diaphragm. Then follow-up study, again, this was a mucus plug. This is what the patient should look like, okay? And then it's what the lower lobe should look like in this patient. This is a person with asthma. Anything abnormal?
Bronchial thickening. Like perihalar bronchial thickening.
Well, when you compare one side of the lung to the other, do you notice anything? Yeah, there's increased opacity here throughout the left side. Okay. Do you have any explanation for that on the lateral view? Yeah, that's right. Looks like there's some increased opacity here also, right? What do you think of the left hilum? Little fuzzy looking, right? Left diaphragm,
Peaked.
yeah.
So there's atelectasis.
Of what? Okay. So what do you think this is then? That's the collapsed left upper lobe. All right. So in a patient with asthma who develops atelectasis, we think the cause is going to be what?
Mucus.
Mucus plugging, right. They develop mucus plugging. So follow-up chest x-ray. So this is what the patient should look like. Okay. So again, look at the difference in the left diaphragm, this whole hazy opacity here. Now, I agree from the frontal view, left upper lobe atelectasis is the sneakiest of the lobar collapses on the frontal view, right? It can always surprise you. You just have these kind of vague abnormalities. But if you notice that there's volume loss there, right, in the left upper lobe, then you can think about it. And then you ask for a lateral view, because the lateral view is the easiest for you to see left upper lobe collapse. You can see the major fissure deviated anteriorly, and then all that opacity there represents the collapsed left upper lobe. Okay? So again, compare this lateral view to the normal lateral view in the same patient. That's what it should look like. This is the collapsed left upper lobe up here. Very similar story, right? So again, we have the hilum looks fuzzy, maybe a little elevated. Notice the diaphragm is elevated. Notice also we lose the left heart border. Why? Why do we lose the left heart border in this case? Well, what's the diagnosis? Yeah, again, it's left upper lobe collapse. You can see the major fissure here is deviated anteriorly. This is the collapsed left upper lobe. So why do we lose the heart border? Well, because the lingula is part of the left upper lobe, right? So if the lingula happens to be in contact with the heart border when it's collapsed, you're going to obscure the heart border. Lingula is part of the left upper lobe, all right? So it's another example of left upper lobe collapse. Another case where we have elevated diaphragm, hazy opacity here on the left side. So we're suspecting of
Left.
right? Is there anything different in this case? we notice anything different? So look carefully at the lateral view. Do we notice anything?
You're talking like the Bushka sign?
Well, what sign are you talking about?
The Bushka, like.
No, the loop sickle sign is a sign of left upper lobe collapse, okay, but that's not what we see here in the lateral view. And remember the prior cases of left upper lobe collapse I showed you, right? You can see what the collapsed lung looks like here, right? See it there in the lateral view? See? Very smooth. What does it look like here? There's a bulging here, see it? So this is analogous to what sign? When there's a bulging of the fissure associated with that atelectasis, usually we see that in the right upper lobe. What do we call that sign? The golden S sign. So it's an indication of what?
Like a mass.
Mass, obstructing mass. Right. So here there's a bulge in the fissure. Whenever you have atelectasis with a bulge in the fissure, you have to worry about a bulging mass. And in this case, there's this large infiltrating tumor, see, encasing the pulmonary artery. So we're looking at collapsed left upper lobe, but because of this large mass causing the collapse of the left upper lobe. All right? So whenever you have atelectasis, look carefully at the fissures. If there's any bulging in the fissure, you have to be suspicious of an obstructive cause, mass causing the collapsed lung, and then we want to get a CT. Okay? All right, so we'll stop there.